truly an honor and privilege to be here. I thank Carol Riff for the kind words of introduction. She has been responsible for many visits that I have made to Madison, Wisconsin, because after the second round of the study, I joined the Midas team, and it's been amazing to follow Carol's great leadership with what the Midas study is able to accomplish. So when a great, respected colleague and friend asks you to come, you do what they ask you to do. That's a weakness I have. But it's good to be here with you. I've had many other visits to Madison also. I've had University of Wisconsin-Madison is important to some members of my family. My sister, older sister, did speech pathology here, and her husband did a PhD in Near Eastern Studies. Hebrew is what he studied. I had a niece who was recently a postdoctoral fellow in neuroscience here. So I've come here for a lot of family events as well. But let me jump to my talk, and it's great to be here and thrilled with the work that Stacy presented this morning. Racial disparities in health, challenges and opportunities. There are large racial and ethnic differences in health in the United States and around the world. I'm not going to show you global data, but I've been collecting data from other countries. It's amazing how similar the patterns are elsewhere. I'll give you one example of the disparities in health, infant mortality, a widely used measure of overall health in international comparisons. It captures the rate at which babies die before their first birthday. And you can see in the United States, Blacks, Native Hawaiian and other Pacific Islander babies, as well as American Indian and Alaska Native babies, have markedly elevated risk of dying before their first birthday, which tells us something of the overall health challenges they face. And COVID-19 has made inequities in health much worse in the United States. This is national data for the United States, the age-adjusted odds ratios of the risk of dying from COVID-19. This is kind of halfway through the first thrust of the pandemic, the first 520,000 deaths. And you can see the death rate for the indigenous, the Native American population, for the Latino population, 2.4 times higher, the Black population twice as high, the Native Hawaiian population 2.6 times as high compared to the white population. So all of the disadvantaged groups were dying at a markedly higher rate. Now it's important to recognize that even though the groups are dying at a higher rate, because whites are the majority of the population, the majority of the persons who died, the overwhelming majority, were in fact white. So the first 520,000 deaths, nearly 300,000 of the persons who died were white. And I emphasize that because there's a study published in Social Science and Medicine about a year ago that found that when whites heard that minorities are dying at a higher rate from COVID-19, they were less likely to take precautions and get vaccinated. They felt they were fine. Not realizing that the majority of the people who died from COVID are in fact white. This is the impact of COVID-19 on overall life expectancy in the United States. We have seen a decline in life expectancy for this country that is larger than we have seen at any time since 1944. That's the decline from 2019 to 2020. And you can see the decline was largest for Hispanic and Black males, more than 3 years. For Black and Hispanic females, 2 years or more. For white males and females, over 1 year. So these are very large declines in life expectancy captures how long the average person lives. And these are declines we haven't seen for many, many decades. Racial inequities in health are also persistent over time. And we have data on Blacks and whites going back to life expectancy at birth only from 1950 to the present, only for Blacks and whites. We don't have data for other groups going back that far. And what these data show is that in 1950, the average white person lived about 8 years longer than the average Black person, so an 8-year gap in life expectancy. The good news in these data is that life expectancy for whites has been increasing over time up to 2010, and for Blacks it has been increasing over time. At the same time, the gaps are quite striking. Look at the life expectancy of whites in 1950, 69.1 years. And let's ask, how long did it take for African Americans to catch up to the health that whites had in 1950? 1990, 40 years later, blacks experienced the level of health that whites had in 1950. And then you can see good news also through 2010 is that the life expectancy gap of 8 years in 1950 is now 4 years in 2010. So it's been in half. Now we would love to eliminate it, but that's still progress. But look at 2020. You can see a life expectancy decline for whites, a life expectancy decline for blacks, and because blacks had a bigger decline, as I've shown you, from COVID-19, the gap was 4 years in 2010. It's 6 years in 2020. So we're going backwards as a result of the impact of the COVID-19 pandemic. So what drives these large racial and ethnic inequities? I was trained as a sociologist. And socioeconomic status, whether measured by income, education, occupational status, and health, is one of the biggest predictors of variations in health in every country in the world where we have data. And racial inequities in health exist by socioeconomic status in the United States. Here's an example of one study that I was involved with years ago, using data from the panel study of income dynamics. And what we looked at here is the risk of all-cause mortality, the overall death rate. Comparing the highest income group, in this study we used $150,000 or more, compared to persons with low levels of income. And what you can see, low-income Americans, income that's about where the poverty rate is, about $25,000, have an overall death rate 3 times higher than high-income Americans. But what you also see, at every higher level of income, there's a decline in the overall death rate. And race ethnicity is strongly related to socioeconomic status. That has come through in multiple presentations again today. Here's median household income and race in 2018 in the United States, but I'm going to translate it in a way you can't miss it. I'm standardizing the household income of whites as $1. And for every $1 of household income that white households receive, Asian households receive $1.23. Asian households are more likely to be multi-generational, so to have more people contributing to household income. Asian households is also heavily made up of immigrants, almost 2/3 of Asians in the US are immigrants, and they've come to the United States with high levels of education. Asians have twice the level of college completion, for example, rate as whites. But let's look at a historical disadvantage group. For every $1 of household income in 2018, whites received, Latino households received 73 cents, and Native American and African American households received 59 cents. Do you know what is stunning about the 59 cents figure for blacks? That's identical to the black-white gap in income in 1978. You heard me correct. I did not misspeak. 1978 was the peak year of the narrowing of the black-white gap as a result of the anti-poverty policies of the 60s and 70s and the civil rights policies of the 60s and 70s. The gap was reduced to 59 cents. It was worse than that before that. And in 2018, it is still 59 cents. Has it been stuck at 59 cents all this time? No, it got worse throughout the decade of the 1980s. Reaganomics was not good for the black community. And it was in the mid-1990s that it got back to 59 cents, and it's a penny up and down since then. My point is, the racial inequities that exist in socioeconomic status are much larger than most Americans think and most of my students think. And the large racial gaps in income markedly understate the racial gap in economic status. What do I mean when I say that? Well, income captures the flow of resources into the household, but it doesn't tell us anything about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth. Your savings, your investments, your home equity, your other properties. And what the Federal Reserve Board tells us, for every $1 of wealth that white households have, black households have 10 pennies, and Latino households have 12 pennies. And when you are low in income and low in wealth, you may all have been in the same storm of the pandemic, but you are in different boats. And boats that are low in income and wealth are just not as able to weather the storm. When my career started, most researchers thought that the racial ethnic gaps in income were simply a function of racial ethnic differences in socioeconomic status. And so, for example, if you looked at blacks and whites at the same level of income and education, race would no longer matter. We now know that life is more complicated than that, and that there is an added burden of race. I want to illustrate that to you with some work we did using national data for the United States, looking at life expectancy at age 25. And we look at the power of socioeconomic status and the power of race ethnicity. So at age 25, average white person lives about 5 years longer than an average African American, a 5-year gap. But here's the power of socioeconomic status. Whites with a college degree in the United States live on average 6.4 years longer than whites who have not finished college. Not finished high school, sorry, than high school dropouts. So there's a 6.4-year gap, and it's similar, it's true if you look at data on income. The income gap within each race and the education gap is bigger than the racial gap. If we look within African Americans, again, the best of African Americans, those with a college degree or more education, live 5.3 years longer than those who have not finished high school. So again, a big gap within each race. So should we abandon collecting data on race and just look at socioeconomic status, since it predicts even greater variation in race? I would say not so fast. Why? Because race matters at every level of income and education. I'm only showing you the education data alone in the interest of time, but the same is true for income. Because you see, white high school dropouts live 3.1 years longer than black high school dropouts. And as education increases, the racial gap actually widens. So there's a 4.2-year gap between black and white college graduates. And remember, this is a study, national data for the United States. And look at what these data are telling us. The best of African Americans, those with a college degree or more education, have lower life expectancy than whites with a college degree, lower life expectancy than whites with some college education, lower life expectancy than whites who graduated from high school. So what do these data tell us? There's something about income and education that matters for your health, regardless of your race. But there's something else about race that matters, even after you've taken income and education. So researchers have been asking, what else is it about race? And what does the scientific research clearly tell us? It tells us that racism and racial discrimination are alive, well, pervasive, and thriving in America, and that racism has dramatic negative effects on physical and mental health, and that racism is a critical missing piece of the puzzle to understand the patterning of racial inequities. And you're saying, well, what's the evidence? So, I'll give you evidence. I'll talk about the house that racism did. And so I begin by defining what do I mean when I use the term racism. I think of it primarily not as the beliefs and behaviors of individuals, but as a modernized societal system that categorizes and ranks, evaluates, and empowers, differentially allocates resources to groups based on those that are regarded as more superior compared to the inferior ones. Yes, it leads to negative beliefs and attitudes, prejudice, and stereotypes to our groups. It leads to differential treatment, that is discrimination by individuals and society. But I want to give you some evidence, and I want to think of the multiple ways in which racism can have health consequences. So first, I want to talk about structural or institutional and upstream mechanisms of racism. This is back in 2001, I wrote a paper with one of my former students about racial residential segregation, policies that determine where Americans could live based on their race, and how it drives inequities in the United States. John Sell was a historian at Duke University. He wrote a book about the origins of segregation in the US South and South Africa. He showed that the framers of apartheid in South Africa in the early 20th century got the idea of apartheid from looking at how well residential segregation was working in the United States. So when you look at South African apartheid, we give them that. That's where they got the idea from. Looking at segregation in the United States. Importantly, Sell argues that residential segregation by race was one of the single most successful domestic policies of the 20th century in the United States because it has such pervasive effects. You say, well, what does segregation have to do with anything segregation as a burglar at midnight. Once it slips into the community, valuables disappear. With quality schools and safe playgrounds and access to good jobs and a healthy environment and access to high quality housing and good quality transportation and health. All of these desirable resources, research tells us, vary by place, vary by neighborhood, vary by zip code, vary by where you live in the United States. And it's not an accident. These are policies that have implemented. Let's look at some data. Two of America's most eminent sociologists, William Julius Wilson and Robert Sampson, studied 171 largest cities in America and said there's not even one city where whites live under equal conditions to those of blacks. And that the worst urban context in which whites reside is considerably better than the average context of black communities. That's what segregation has produced. But if you look carefully, that's a 1995 study. Have things gotten better? So I'm drawing the work of Professor Dolores Azevedo Garcia from Brandeis. She's created a neighborhood opportunity index, ranking every county in America and most census tracts on 29 different indicators of access to opportunity for kids. Things like the quality of schools, and the high school graduation rate, and the income level, and the home ownership rate, and employment, and access to high quality air and water, and resources for health. These are just some examples in 5 categories of 29 different indicators of access to opportunity for children. And then, in a 2020 paper in Health Affairs, she analyzes data for the 100 largest metropolitan areas in the United States. And she asks a simple question: which children live in the very low and low opportunity neighborhoods in the 100 largest metro areas in the U.S. 67% of all black children are living in the very low and low opportunity neighborhoods. It's also true for 58% of Latino kids and 53% of Native American kids, compared to 1 in 5 white and Asian kids. Who lives in high opportunity neighborhoods? Which children? Almost 2/3 of white and Asian children, compared to about 1 in 5 black and Latino kids live in very high and high opportunity neighborhoods. So place determines access to opportunity in a profound way today, even though the policies that created segregation are no longer legal in the United States today. And research documents that segregation is the central driver of the large racial ethnic differences in socioeconomic status that we see in the first place. This is David Cutler, an economist at Harvard University, using national data for the United States, using fancy econometric models I cannot even fully describe. But he's able to show statistically, if you could simply eliminate residential segregation in America, you would erase completely all black-white differences in income, in education, in unemployment, and reduce black-white differences in single motherhood by 2/3. All of those differences are linked to opportunity at the neighborhood level. One more study, one more economist, Rash Chetty. He's done an amazing intergenerational analysis using access to all census data from 1989 to 2015. And he asked an intergenerational question. He says, let's look at black and white children. And let's control on household income. How are the children doing in the next generation? And you know what Rash Chetty found? Black boys have lower earnings than white boys in 99% of census tracts in America. Census tracts are geographic areas. In 99% of census tracts, they do more poorly. Why? Because they're not working hard enough. Why? Because they're lazy? No. They live in neighborhoods that differ in access to opportunity. Black boys, as well as white boys, if they're in neighborhoods with good resources, but there are few such neighborhoods in America. Segregation also leads to higher exposure to a broad range of stressors. This is a study we did in Chicago some years ago, that blacks and Latinos have higher levels of major life events, of financial stress, of relationship stress, of neighborhood stress. It's a broad range they are much higher. And a recent report from Robert Burland, published just this year, looked at the relationship between segregation and exposure to chemical stressors. In highly segregated areas, residents of those areas are more likely to have high rates of being dumped and poisoned in their homes, neighborhoods, playgrounds, breathe air that is more toxic, have almost twice the density of oil and gas wells in their neighborhoods, and therefore encounter more natural gas leaks, more likely to live close to dirty energy, and they have fewer resources to recover. So the chemical exposure and what climate change is doing is going to have a disproportionate negative effect based on where we live. And here's a study by Gary Evans and a recent article just published earlier this year that looked at 6,000 elementary school children, and what it found, that exposure to air pollution led to less progress in reading over time. And in some of the schools that they studied, there was a remedial program, an intervention to improve their reading ability of the kids. Those kids who were exposed to air pollution, remember they start out not being able to read as well, not doing as well, less progress in reading. Those who got the intervention, the air pollution diminishes the efficacy and impact of the intervention. So even the intervention is not working as well when there's the exposure to air pollution. So just an example of the negative impacts that this has. And then segregation affects access to medical care. And this is a paper where we review the ways in which the concentration of black and brown low-income populations leads to an epidemic of pre-existing comorbidities and poorly controlled chronic diseases. In segregated neighborhoods, there's a shortage of primary care providers and a severe shortage of specialists. And many of the primary care providers, they don't have admitting privileges at the best hospitals where they could get the best specialty care. And there's the resulting receipt of suboptimal care. The point I am making today, please don't miss it, is that these inequities in health that we see, in economic opportunities that matter to them, do not reflect a broken system. Instead, they reflect a carefully crafted system, functioning as planned, successfully implementing social policies and practices, many of which were rooted in racism. These inequities are not accidents, they're not random events, they're not acts of God. They illustrate the way, and I've only talked about one mechanism of racism. The upstream mechanism of racism, segregation, has produced a truly racist system in the United States. But in addition to these upstream mechanisms, there's individual discrimination that is an added source of stress, and we've seen the impact on cognitive functioning later in life. Martin Luther King was not a scientist, but this is a hypothesis. He says that discrimination is a health problem that knows that Negroes in every waking moment of their lives declare that the lie of their inferiority is accepted as a truth in a society dominated. That was mentioned on the Everyday Discrimination Scale, one of the measures of discrimination that I developed when I was at Michigan. Today, one of my students documented in a recent meta-analysis. There are more than 450 papers published from around the world using the scale documenting this negative effects. Importantly, it does not capture all aspects of discrimination. Just the little indignities, being treated with less courtesy or respect, receiving poorer service than others, people acting as if they think we're not smart, they're afraid of they think we're dishonest. And just to illustrate the power of it, I'm joining the work of Tenny Lewis, who's at Yale, now at Emory University. Each line on this slide represents a different published peer-reviewed study, linking everyday discrimination to higher levels of coronary artery calcification, to higher inflammation, to higher blood pressure. Pregnant women who report everyday discrimination give birth to lower birth weight infants. The study of the elderly over time, higher levels of everyday discrimination predicts more rapid declines in cognitive function. Linked to poorer sleep. The study of adults followed over time, high levels of everyday discrimination is an independent predictor of premature death. Linked to elevated mortality risk, or higher levels of visceral fat, higher short telomere length. Just to illustrate, I have been been surprised at the power of the stress in terms of affecting a broad range of physical and mental health problems. And this research indicates there are hidden ways in which stresses linked to race and racism can adversely affect health. Here's a study of black women in America. 70% of black women were very concerned that their children might be harmed by the police. What does that do to their stress and anxiety levels? And there's reason for it. Here's a study of 3,000 mothers in the Fragile Families study, a large study of looking at kids in 20 cities. Almost a quarter of these urban youth have been stopped by the police by the age of 15. And mothers of youth who were stopped by the police are more than twice as likely to report depression and anxiety-related sleep difficulties. Here's a study I did with one of my students. We took a database of every police shooting in the United States over 3 years, and we linked it to another database from CDC of the mental health of the population in every state. And what we found was that every police shooting of an unarmed black person led to worse mental health, not just for the family and friends, but for the entire black population in the state in which it occurred for the next 3 months. Worse mental health for 3 months. And it wasn't every police shooting. It was a specific effect. It was only police shootings of an unarmed black person. If a black person was armed and shot by the police, there was no negative effects on them. We believe that it's the fact that the person is unarmed raises the possibility you don't have to be doing wrong for this, you to be vulnerable to this happening to you, or your family members, or people you care about. All of this, and I think Stacey mentioned weathering hypothesis, Ali Geronimo's developed it. The notion of weathering is that when you are living in a bad environment, your age is not only capturing how long you have lived, but how long you've been exposed to bad environmental conditions. And the notion of weather, imagine a drop of water falling from the rooftop of this building to the concrete sidewalk. This is what a drip did today. It's no big deal. But if it drip day in, day out, week in, week out, month in, month out, year in, year out, what happens to the sidewalk? It becomes weathered. It becomes eroded as a result of a constant exposure to adversity. And what the work of Alan Geronimus and others, researchers who follow the lead shows that black people in America are literally aging physiologically more rapidly than whites because of the higher levels of exposure to such a broad range of stressful life events. And one indicator of that is the earlier onset of disease. One example from CDC, you can see at age 50 to 64, 41% of whites have hypertension. But that's true for 61% of African Americans. Early onset of disease, this pattern is true for many chronic illnesses. So I've talked about 2 mechanisms of racism. I also want to touch base quickly on cultural racism. Racism embedded in stereotypes and a statement that leads to implicit and explicit bias. And these stereotypes trigger discrimination, including discrimination within healthcare. This is the unequal treatment report published 20 years ago, 2003. There's lots of activities celebrating, acknowledging what was documented in 2003, that blacks and other minorities receive poorer quality care in the United States. This report from the National Academy of Medicine, reviewing the scientific evidence documenting this pattern. Recent studies indicate the problem continues. I'll share with you 2 in the interest of time. 1, the study of 1.8 million hospital births in the state of Florida over decades. When cared for by white doctors, black babies are 3 times more likely than white newborns to die in the hospital. The disparities cut in half when black babies are cared for by a black doctor. This study doesn't tell us what's causing it. It suggests there is a huge problem. Here's another example. A study of 318,000 Medicare patients. These are older patients with advanced cancer in their last few weeks of life. And the question is, are they getting opioid medication for their pain? Older black and Hispanic patients are less likely to get opioid medication get medication for pain, they get smaller doses. And black patients are more likely to undergo urine drug screening. These are advanced cancer, dying, but they're still screening them for opioid abuse in their blood. And black men experience the greatest inequality in terms of both access to opioids and experience of urine drug testing. These studies just illustrate, this is a 2023 publication, this is not ancient history. This problem of inequities in care still continues in the United States. And what our society is doing to address these inequities and implicit biases is not working. In isolation, diversity training is not effective. Don't take my word for it. A review of 900 studies found little evidence that diversity training reduces bias. I'm not saying it's useless. It can increase knowledge, it can increase attitudes, but it doesn't change the underlying behaviors. Another review of 400 studies of implicit bias training, same thing, can increase awareness, but does not change deeply ingrained behaviors. So there are strategies that reduce implicit bias. And I talk about the divine solution. Professor Patricia Devine from the University of Wisconsin-Madison. She has developed a program that is effective in reducing implicit bias. She is able to get non-black adults to increase their awareness, to increase their concerns, to implement multiple strategies, to produce successful reduction in implicit bias at the end of the program, and 3 months later, it's still the reduction is still evident. So this is the single most successful program. And why? What is she doing that's different? It's not a 2-hour workshop, it's a 12-week program. You come for 2 hours a week, and you get practice exercises. You don't change deeply ingrained habits that we have with a 90-minute online video. It takes practice, it takes homework in order to do it. So there are things that can be done, but much of what is being done isn't working. What else can we do? We need to build more health into the delivery of medical care. We need to ensure access to care for all. It's a tragedy that we don't do that in the United States. We need to diversify the workforce to meet the needs of all patients. Here is a randomized controlled trial. That's the highest quality of scientific evidence. What they did, this was done in San Francisco, took 1,300 black men, give them a voucher to go to get a Saturday morning clinic, free clinic. When they got to the clinic, they were randomized to see a doctor of their own race. They were all black, or a doctor of a different race. What the study found was those black men who saw a black doctor were more likely to talk about other health problems, more likely to do the screening for diabetes, more likely to get the flu vaccine, more likely to do the screening for blood. So much more engagement when there was racial concordance with providers. We face a huge challenge. This is the underrepresentation of blacks and Latinos in multiple professions. You see 5% of medical doctors are black in the United States, not much change over time. And you can see it's true for dentists, nurses, pharmacists, the underrepresentation of these populations. However, there is some good news. Another study from North Carolina that documented there were racial disparities among persons with HIV/AIDS. In this study, though, the researchers had administered a cultural competence scale. And they found that when a provider was high on cultural competence, regardless of their race, there were no disparities in health among these patients. What did it mean to be high on cultural competence? Providers who agreed that family and friends were as important to health as doctors, who said social history contributed to how they cared for their patients, who said they were familiar with the lay beliefs that patients had, who said they asked their patients about alternative therapies they use, who said they find out what patients think is the cause of their illness, who said they involve patients in decisions about their health care. So what do you see in these questions? Doesn't tell us how to get there, but you can see providers who care, who listen, who ask questions, who respect their patients, and when those conditions were met, regardless of the race, there were no disparities. So it talks about the quality of the interpersonal interaction. What else do we need to do? We need to provide care that addresses social context. The World Health Organization asks, what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick in the first place? And there are multiple examples of programs like that. I'll give you one example, the Medical Legal Partnership, born at the Pediatrics Unit of the Boston Medical Center some 30 years ago. It's now in more than 300 hospitals in the United States. A primary care provider at the Boston Medical Center, when Dr. Zuckerman developed this program, could refer a patient in pediatrics to a number of specialists. One of the specialists is a lawyer. Yes, the hospital has lawyers and law students to solve problems in the lives of patients. Think of a mother bringing a child who has asthma, and the asthma is secondary to the housing conditions in which it is. All the asthma medication in the world will not help that child to be symptom-free if the child goes back to live in the same conditions that cause the problem. And the mother has complained to the landlord who's done nothing. It makes a difference when the lawyer calls and says you're in violation of the housing code in the state. We will sue you if you don't fix the problem. And so there are more than 300 hospitals that have followed Dr. Zuckerman's lead and has involved lawyers and law school students in the care of patients. Providers can refer the patients there. It's an example of taking the social context more comprehensively. This is a report from the National Academy of Medicine that describes many examples within the healthcare system where this is being done in the United States today. What else do we need to do? We need to identify supportive and protective factors and resilience resources and emphasize them and strengthen them when we can. I'll give you two quick examples. One from Dr. Gene Burley. He has been studying African American teens in rural Georgia. Those teenagers who score high on discrimination at age 16, 17, and 18. By age 20, I didn't say age 40, I said by age 20, they have high discrimination as a teen. By age 20, there's biological dysregulation, high levels of stress hormones, cortisol, epinephrine, norepinephrine, high levels of blood pressure, high levels of inflammation, high BMI. By age 20, due to exposure to discrimination. The good news is, those teens who are high on discrimination, but embedded in good social relationships with their parents, their teachers, and their friends, there is no relationship between discrimination and biological dysregulation. In other words, the quality of social relationships blunts the negative effects of exposure to discrimination on their health. The study, National Data for the United States, that documented high levels of discrimination among African Americans leads to worse mental health. Three aspects of religious involvement: frequency of church attendance, receiving support from persons at your place of worship, and seeking religious guidance in your everyday life. Each of these reduce the negative effects of the stress of discrimination on their mental health. But we also need to move further upstream and create what I've called communities of opportunity to minimize, neutralize, and dismantle the systems of racism that create inequities in health. We need to enrich the quality of neighborhood environments, improve economic development in poor areas, improve housing quality and the safety of neighborhood environments. And here is a list of things that could be done. In the interest of time, I'm going to elaborate on two of them. Invest in early childhood. This is the Abecedarian Project in Chapel Hill, North Carolina. They took poor children, 80% of them African American, and at birth, randomized them to go into an early childhood center where they were in a safe, nurturing environment, good nutrition, good intellectual stimulation, good pediatric care. There's a control group that didn't get that. By age 21, and the program, by the way, is birth through 5. After 5 years, nothing happens. Just birth through 5. By age 21, those who got the program, better mental health, better physical health, less drug use, greater success in academics, and greater success in those who are working. By the mid-30s, lower risk factors for cardiovascular disease and metabolic disease in their 30s linked to what happened to them birth through 5. Research indicates that programs like this, these early childhood intervention programs, literally save society money. It's one of the best investments. A preschool project in Ypsilanti, Michigan, that did something similar from 40 years later. For every dollar invested, a $17 return to society. Why aren't we doing more of this? We have the evidence, we have the science, it works. Here's an example of the systolic blood pressure differences between a control group, poor kids who didn't get a program, and those who got a program birth through 5, you see remarkably lower levels of systolic blood pressure. I want to talk about neighborhood and housing conditions because most people think that's so difficult, so complex, so complicated, there's nothing we can do about it. I want to tell you about purpose-built communities, an example of striking neighborhood transformation in the United States. Come with me to East Lake Meadows in 1995. It's a public housing project where 90% of the residents are victims of a felony every year. Dilapidated public housing. Only 13% of adults employed. The local elementary school was one of the worst performing in the entire state of Georgia. Come with me to the villages of East Lake. They tore down the housing project and built a new mixed-income housing development. I was able to spend a day at purpose-built communities with my colleague Jack Shankar, 6 years ago. There's been a 70%, 73% reduction in crime, 90% reduction in violent crime. It's high-quality, privately managed mixed housing. Half of the residents qualify for public housing. Half of them are market rate. All able-bodied persons are employed. The school, where 60% of the elementary students at the school qualify for reduced price lunch, so they're coming from poor households, 60%. The school is one of the best performing in the state of Georgia. It shows that it can be done. What's the keys to the purpose-built model? Mixed income housing, cradle to college, high quality education with local control. It's a charter school. Community wellness and resources they have embedded within the facility, all the resources individuals need to solve their problems. Economic vitality, a defined neighborhood, a community quarterback. They need the local community to identify some quarterback in the community who either brings private money to the table or can work with other organizations to get private money to the table. Do you know what's striking? Purpose-built communities is provided, the board is now being led by Shirley Franklin, the former mayor of Atlanta. And they are providing free technical assistance to any community in the United States who want to replicate their model. I spoke for a conference they had, and there were more than 600 people from across the country who were there trying to understand how can they replicate purpose-built, and there are more than 28 sites approved in the United States replicating the purpose-built model. It's possible if we make up our minds to do it. I also want to leave you with an innovative initiative from a healthcare institution. Rush University Medical Center in Chicago, an academic medical center. The leaders of Rush University Medical Center looked at the data of life expectancy in the census tracts they served in Chicago and found that in some census tracts, people are living 16 years longer than in other census tracts. And the low life expectancy census tracts were racially segregated from the concentrated poverty. And they decided courageously that they would change their mission from being a facility focused on healthcare delivery to being a facility, and they have multiple institutions, focused on improving the health of the community. Please read about it. New England Journal of Medicine, Catalyst, May 2021. They recruited 5 other health systems in metropolitan Chicago to join them on this mission. They created listening sessions to hear from the community what was their priority. And they have decided to use all of their economic might to build wealth within the community and provide employment within the community. Their goal is to reduce the life expectancy gap within their service area by 50% in 10 years. And what have they done? They have developed employment preferences to people who live locally. They've developed apprenticeship programs in starting with kids in high school in the summer. But people who don't have skills, they've opened up new areas of employment so people can sign up for jobs. They've decided to purchase supplies whenever possible locally and even get new local entities into business. You see, the healthcare system is the largest employer and the biggest business in many communities. And what they've decided to do is use all their business might to help the local community. They provided financial education to the local community, even provided incentives to their employees if they volunteer for local organizations, community organizations. It's a dramatic example of what can be done if we make up our mind to do it. So I'm saying we have evidence of what works, of strategies that could make a difference. What's holding us back? What are the barriers we have to address? Now, I wouldn't say this because I wouldn't have the courage to say it, but I'm going to read to you what Martin Luther King said back in 1967. The majority of white Americans consider themselves sincerely committed to justice for the Negro. They believe that American society is essentially hospitable to fair play and to steady growth toward a middle-class utopia, embodying racial harmony. But unfortunately, this is a fantasy of self-deception and comfortable vanity. Overwhelmingly, America is still struggling with irresolution and contradictions. It has been sincere and even ardent in welcoming some change, but too quickly, apathy and disinterest rise to the surface when the next logical steps are taken. Profound words that are worth thinking about. There are three challenges we have to address. One is to raise awareness level of the challenges I've just described. Most people don't know what I just shared with you. Secondly, we need to develop the science base of how do we create the political will so that, okay, we know there's a problem, we work to address it. And third, how do we build empathy? How do we tell the story of the challenges of disadvantaged racial ethnic populations in this country in a way that resonates with the public and that people say, we are willing to do something about it? W.E.B. Du Bois, a great sociologist of the late 19th and early 20th century, wrote a book called The Philadelphia Negro, published in 1899. There's a chapter on Negro health, and he describes the data on the disparities in health and wards in Philadelphia. And as he comes near to the end of the chapter, he says the most difficult social problem in the matter of Negro health is what he called the peculiar attitude of the nation toward the well-being of the race. And he said there are few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. He said the fundamental problem is we do not care. He called it the peculiar indifference. Scientists today call it the empathy gap. And it's been documented on every continent. We feel the pain of what's happening to someone of our own group compared to someone of another racial group. There's studies in Europe, Africa, Asia, the US that documents this. There's a study that finds among white children aged 5 years old, there's no empathy gap. If you show them someone being stuck in the arm with a needle, they see a black person and a white person experiencing the same amount of pain. By age 7, they tend to see the white person experiencing more pain than the black person. By age 10, it's pronounced. By age 10, a reliable empathy gap is evident within the U.S. population. There's work we have to do. We also need to realize the benefits of the inclusive policies, building these communities of opportunity. There are more poor white people in America than poor black people. Almost twice as many poor white people as poor black people. So the strategies of building communities of opportunity will help all populations, including the white population. I leave you with two quotations. can no longer be silent. And finally, the words of Robert Kennedy, speaking in South Africa in the 1960s during the height of apartheid. And he said each time a man or woman stands up for an ideal, or acts to improve the lot of others, or strikes out against injustice, he or she sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance. It's my hope that each one of us today makes a new commitment to be a tiny ripple of hope. And together, we can sweep down the mighty walls of oppression and resistance. Thank you so much for your time.